Okay, everybody, we are live. This is extremely exciting to have these people and this conversation going on today. Before we get started, I just want to say hello, healthcare, hello, LinkedIn, hello, YouTube, hello, everybody coming to this, watching in whatever way that you can. We know that we have a diverse audience here, multidisciplinary, focused in patient engagement, marketing, IT, and we're excited to have Dr. Zachary Hermes here to discuss health equity as the North Star to all of the work that we're doing uh, to improve the patient experience and make their journeys better. Uh, Dr. Zachary has a deep background in a lot of different things. You might have noticed if you saw his LinkedIn account that he's got a background in medicine, along with public health and law at the same time. And it was a great first conversation with him regarding, hey, why those focuses in education, and it's because there's a lot of barriers that exist between those fields that need some interplay, and we're going to talk breaking down those barriers in terms of health equity. Any words before we get started?
I just want to say welcome to everybody. It's a real pleasure to join, particularly with I think the mix of folks who will be joining this conversation and engaging. So I hope people feel comfortable to throw questions in the chat, and would love to make this as interactive as we can. As you said, health equity is my North Star, and I think it is generally the direction that we all need to be able to make the changes we want to see.
Excellent. Colette, Terry, thank you for joining. We appreciate you. And as you said, it's a conversation between us. So if there are questions, especially, I know that there's a lot of people, hearts in the right place, want to do the right thing and make healthcare equitable, but there's questions of how, there's questions of how to operationalize it. There's questions on care pathways and journeys. So we're excited to have you ask your questions and share your stories so that we can get some answers to some of those things that might be burning in your minds. Again, also, we're joined by Sheetal Shah, who is the COO for Symphony RM and has led digital transformation efforts at top 10 health systems in the nation. But okay, I think it's about time we get started. David Dalton, thank you. Just to level set and make sure that we're all on the same page and playbook here. How do you define healthcare equity? What is healthcare equity?
Well, I'll start with health equity because I think that's an important distinguisher that we talk about the difference between health equity and healthcare equity. Because what we're really talking about with health equity is creating the environments and ecosystems that create a fair and just opportunity for all to be healthy as possible. Again, equity is about recognizing the barriers that prevent really this emergent quality, which is health. When we talk about healthcare equity, what we're talking about is really recognizing the disparities that prevent people from accessing care, recognizing that there's a differential burden of those obstacles, and addressing and investing where the burden is greatest. So I think those are two important distinctions, but the equity piece is essential in both.
And Sheetal, your thoughts on the
yeah. I'm actually that was actually a really cool distinction where one aspect is just the totality of health and wellness, but the other side was access to care. And I'm actually really curious to hear from Zach. You went to medical school. You have a master's in law and public health. And it's of recent, right? Like just this, you're the newest generation, and actually it's the most inspiring for me to see this. What are you seeing technology come in play, or is there an impact that technology can have to improve equity of healthcare services, healthcare resources? And I know healthcare in many ways it's even bigger than just accessing the traditional medical landscape. Is there a role for technology? Like, have you seen that shift? Because in many ways, your graduating class was the first that had the access to tools that I think years before, decades before, had not. with?
It's a great question, and I think it's one of the most exciting aspects of what I see this generation of health delivery that we're coming into. I think we know that healthcare is profoundly human first and foremost. So I think when we always consider how technology can empower us, what we really have to ground our thinking in is digitally and technologically enabled humans, right? How can we provide digital tools? How can we provide analytics that are going to empower those humans at the point of care to make the right decisions, to identify the right patients and provide the right care at the right time? I think that's where I'm most excited about how technology can truly facilitate and advance efforts to achieve healthcare equity, as well as just effective healthcare delivery. I can kind of break down each of those points and maybe even give some concrete examples of the work that we did. Sorry.
Oh, no, you go ahead. Go ahead.
Would love for you to break it down.
Yeah, no, absolutely. So I think, starting with one simple example, one of the most, I think, profound experiences I've been able to have is integrating food insecurity into the nuts and bolts and core operations of both primary care and cardiovascular services in Atlanta at Grady Memorial Health System. One of the things that folks don't often recognize or realize is that food insecurity can have a profound impact on the effectiveness and outcomes in diet-related illnesses like diabetes, heart failure, some of these conditions that we know create the biggest burden of utilization of care, of negative outcomes. So what we were able to do was to integrate the collection of food insecurity data into our intake processes. And for patients who we found to be positive, we were able to leverage that data to plug them into care pathways that addressed those needs. Through addressing those needs, we were actually able to improve the outcomes that we cared about, which were 1, medication adherence, and 2, hospital readmissions. So I think that's one clear and simple example of being able to collect data and then have integrated analytics that can immediately pull that person into a uniquely designed pathway. I think another way that I've seen being profoundly helpful is using digital tools to really facilitate engagement in real-time, ongoing connection between providers and patients who sometimes otherwise find it difficult to get into an appointment, who find it difficult to take off from a day of work or to take the bus. Really being able to leverage nurse practitioners, really a multidisciplinary team, pharmacists, behavioral health therapists, who outside of the appointments can leverage digital engagement to really be able to promote those outcomes that we care about. So I think when you can marry the two, those analytics, particularly focused on health-related social needs, and integrating that into the bundle that gives us a picture of the patient, and then empowering really a team-based approach to leverage digital engagement is a really exciting opportunity.
That is really cool, because I remember about 10 years ago, the big thing in the analytics space was identifying the food deserts, right? And you're talking about food security and the like, and some of the work that you're doing there. Actually, one of our clients, Virtua Health, has a real cool mobile grocery store. So instead of just talking about where the food deserts are, it's actually physically doing something about it. How are you inspiring teams to rethink? Like, the traditional healthcare model never included that. So how do those conversations start? Like, you recognize that there's a problem around access to healthy food that's affordable, but then how have you seen some of the change actually take place?
It's not always easy. And it really requires champions. It requires champions who are willing to go to bat and sometimes engage folks who hold the purses and control the ability to invest in some of those infrastructures to help them understand that though this may be considered, an alternative investment, this directly is going to be tied to those impacts and those outcomes that we truly care about. So for us, we were able to leverage a champion who had I think both social and political capital in the organization, who could continually engage the right folks to make those investments that would empower us to build the team, to build the structures that would allow us to integrate this pathway into care. So I think, again, it is all about humans and inspiring, activating, and bringing folks together who sometimes are otherwise working in sometimes disparate silos. So for us, again, that meant bringing together social workers, dietitians, and pairing them with nurse practitioners and physicians to really understand that we have a clear vision, and then being able to take that consensus to the administrators and operators who then could invest.
I love hearing the pathway from data collection and analytics to some sort of action that's taking place to help people receive better care. And I also love hearing about the coalition building that you were referring to in the multidisciplinary effort. I'm curious, just especially for people who might be in different departments, what are some obstacles that were encountered in that path, or what should people be prepared for when answering to the stakeholders and the people who hold the purse strings?
Well, I think, again, it always comes down to having very clear metrics that you can call to say this is going to be the return for our investment. So for us, we were able to leverage a strong database or literature and evidence base that demonstrated some of the impacts of interventions around food insecurity on medication adherence, on hospital reutilization. So I think as you're bringing together a team, as you have identified a problem, very clearly being able to define these are going to be the outputs of addressing this problem and solving this problem. Because I think what we found is early on, even when we could bring those very clear returns, it took time, it took coaching for folks to really understand. I think one of the other key pieces, and this is where I've really leveraged my multidisciplinary background, is understanding, as you said, for the most part, folks do have their hearts in the right place, but there are translation gaps, we can say. People are able and used to thinking in the terms and in the vocabulary of their silo. So really starting to understand where the translation needs to occur and what needs to be translated across an IT department to an operation or finance department to your providers, and understanding that each of those silos are often used to a very unique vocabulary, but being able to really clearly and thoughtfully identify where those gaps are, I think is immensely helpful as well.
So, Zach, you were kind of connecting a few different points, and you started with the thesis of healthcare is very human. It's very personal, and that healthcare is not only just access to medicine, but the many of the basic necessities of life, access to healthy food, even transportation and the medication, adherence and the like, the elements that are all coming together. In many ways, it's almost reestablishing trust between a health system and their community. Do you see that actually being a huge factor in allowing, because there's a lot of technology these days that help connect a patient to a health system, but if there's no trust, those tools will all fail. I know that when we talk about health equity, a lot of the underlying roots of the issues that have led to less equality or equity in this space has been trust. Do you think that there is a movement of rebuilding that trust between the traditional healthcare model and the underserved?
I'm really glad that you called this point out, because it is at the core of, I think, what we're talking about, and I think it's actually very relevant to the audience, an audience that, to my understanding, is thinking about marketing, patient engagement, and I think it actually, again, really is closely tied to health equity, because recognizing, again, that those barriers to health equity are represented in housing disparities and inequity, in transportation disparities and inequity, in food insecurity, economic instability. When you're trying to engage a patient who's dealing with these barriers, but you want to engage them to come in for their colonoscopy, but you're not at all recognizing that these barriers are often at the front of their mind,
Yeah,
you are going to maybe not be fully understanding why you're not successful. So I think particularly as we kind of continue to move forward in this arena and ecosystem where we actually have much more holistic pictures of patients, leveraging social determinants of health data, really being able to be thoughtful about, okay, we recognize this healthcare need, but let's also think about what metrics we're seeing in terms of the social determinants of health about this patient. And maybe when we engage with them, we actually lead with that because it's the most important factor to that patient. And when you lead with that, when you lead with their needs, that's how you build trust. That's what makes people feel I'm being seen.
So, just thinking back a little bit, I mean, we've covered a lot of ground today regarding technology, coalition building, access, and really the center point between all the different fields that you're bringing together in your studies and your career. I'm curious if we backtrack, what got you started on this journey, or what got you passionate to go down this pathway?
If I'm going to be, fully honest, it really tracks back to an early experience I actually had in college. And I have to call out the University of Washington School of Medicine, which was one of my first really in-depth experiences. And there, the University of Washington is renowned in their work in primary healthcare, in community health, and really holistic and integrative approaches. So that experience for me was grounded in that perspective. And it was also grounded in a real call to action to think about, as a physician, as a health system, the platform and the resources that we hold and have, and how we are actually positioned to be much more than just the prescribers of medicines, the proceduralists, or diagnosing diseases, when in fact we can very clearly call to these broader factors that are shaping the outcomes for individuals and communities. And as anchors often in our institutions, we must take on that duty, and it will only help us do our job more effectively. I think as we continue to move forward in this realm of accountable care and value-based medicine, obviously health systems and providers are being forced to think about this. But I think the more you can actually take ownership and recognize actually it is an asset, as an opportunity to truly lead in this work, I think that the opportunities are endless. So I have to really call back to that first experience that challenged me to think about what my role as a physician can mean beyond just taking care of the individual patient from a clinical perspective, but recognizing that as a physician, as a provider, we have such a unique insight into the lived experiences of our patients, and owning, stepping up to that responsibility makes it incumbent on us to leverage the resources that we have to more effectively intervene. And if it's not even within the healthcare system, we have a really powerful opportunity to bring together the coalitions, the cross-sectoral interventions that actually can address those fundamental root causes of illness.
We got a question from the audience, and it harkens back to a concept that you introduced when you were talking about the using social determinants such as food insecurity on the impact on med adherence and other factors. Amy Bender, actually from our company, she brought up another point, which I've placed on screen here, which is curiosity on the effect of adverse childhood experience on health and adulthood, whether something there within healthcare is something that we should be paying attention to.
No, I think it's a great question, Amy, and I think almost certainly there's a recognition that maybe not clearly or wholly focusing on adverse childhood experiences, but recognizing and understanding how those later manifest in behavioral and mental health conditions that often make physical health and wellness complicated. So I think it's a real call to saying what we need is really to integrate behavioral therapy, behavioral health into the core of our processes I'm interested particularly in cardiovascular medicine, and there's a growing recognition of the role and the need to have mental health and behavioral health really even integrated into cardiovascular services, because there's often a really profound impact. There's data that shows mood disorders and depression can significantly impact outcomes following a heart attack, myocardial infarction, or heart failure. So I think, Amy, what your question is getting at is this idea of really always recognizing, understanding the behavioral and mental and emotional well-being of our patients, and actively integrating that into any physical conditions we're managing is essential if we want to deliver effective care that's going to meaningfully improve outcomes in the long run.
Another point that you had brought up earlier was around how value-based care is kind of forcing a new perspective on how health systems look at the care that they provide. I was curious about, there's a lot of new trends such as value-based care and the shift over to digital health and virtual care. Where do you see these new avenues and these new modalities and ways of thinking in helping to serve the underserved?
Yeah, I think, again, I'll try to separate those two out, because when we think about value-based care, accountable care organizations, and there's within that umbrella, we have many different iterations, from bundled payments to hospital readmission programs. So there's really a litany of ways that manifests, but at the end of the day, what it means is how you are going to be paid or reimbursed is going to be tied to the outcomes that you and your patient experiences. So what that means for an organization is, again, you have to recognize these social determinants of health. You have to recognize these drivers of health inequity, because if you don't, your patient's going to do worse. And that's the literature, lived experience bears that out over and over again. So that's where I see a really strong convergence between health equity and health systems innovation. This is an incentive that's forcing us to recognize this importance, and is also giving us some ability to invest, because often when we think about value-based payment in accountable care organizations, that also starts to translate to capitated payments, which means you're not deciding or you're not built around volume. You're not built around the procedures or interventions that are always going to drive the highest amount of revenue. Instead, you're getting a bundle, or you're getting a certain allocation per patient, and then you can choose how to invest those dollars. You can choose which types of interventions, which types of teams you want to build that are going to be able to deliver those outcomes. And I think that it's a really strong opportunity to, as I said, build some of those multidisciplinary teams that can really holistically begin to approach patients. As I think about how digital health begins to contribute, I mentioned some aspects of how it can be leveraged to engage patients, but I think we also have to always be aware of the reality that there's a digital divide, right? And that was one of the things that came up in our first conversation, Chital, is that not everybody has an iPhone, not everybody has an Android phone, and there can be even if you have a Metro PCS, for instance. I think that was one that actually came up. There are implications to what digital engagement means when you have some of those different options, or you don't have a phone at all. So there's a real risk that this digital care divide could actually potentially worsen health equities and health inequity if we don't remain very thoughtful about it.
Zachary, actually, I had a question on that front, because you're right. Digital divide can get actually larger as healthcare organizations start shifting, as they start shifting dollars, their investments, to help connect to consumers closer with virtual care. We're starting to see a lot of remote patient monitoring opportunities and the like. When we're hearing a lot about technology that leverages AI. When we first spoke like a month or two ago, we talked about the impact of AI on digital health. But there are some questions that really have to come up if you're going to leverage AI to deliver care, and how AI is being used to identify who to engage. What are some of the questions that you think healthcare organizations should be asking of their vendors?
Absolutely. And you know, I wouldn't be honest if I didn't give Chris the nod on this conversation or point. But the reality is that if you're leveraging algorithms to identify who's appropriate for particular interventions, if you're leveraging algorithms really in any way, what you have to be asking your vendors is, how is this algorithm performing across different populations? And why is it performing differently across populations? Which variables are driving that differential? If you're not asking that question, you're almost certainly likely failing, and that there are blind spots that you are not aware of and your vendor may not be aware of. So I think that's almost a non-starter. Without that question, without some clear, concrete answer to how this program or algorithm is performing across different populations, particularly thinking about race, socioeconomic status. If somebody can't give you a clear answer, I would certainly encourage some pause and some caution.
Yeah, my big mentor in this space has been our moderator, Mr. Chris Hempel here. Chris, there are some words that I know that you've been teaching us about asking when vendors come in and talk about AI, and it has to do with, like, I think, explainability, or like, can you give us a little, like, 1 minute on what are the other ones that we should be looking at?
Yeah. So what you're at, the most important question that you're asking of AI is, hey, what are you optimizing for? If you're and there's a couple of things that you'll find that are pretty commonly optimized for, such as precision, which is the rate of false positives, or recall, which is false negatives, or how many people are we leaving from the conversation or leaving from the outreach that's necessary. So those are commonly known as type 1 and type 2 error. The one that doesn't get talked about enough is type 3 error. A type 3 error is, hey, you might have a model that performs extremely well, but it might be performing well on a question that's irrelevant to the population that you're trying to serve. A good example, and this is based on work from Dr. Ziad Obermeyer and a research team that he was leading. There's actually a lot of recent news from Stat News about this, but this particular organization, they were optimized. The algorithm was trying to determine how ill somebody was, or their risk level, based on the amount of spend that they had. So I would call that a type 3 error, because spend might be loosely correlated with illness and the number of comorbidities that some people have. But if you're in my segment of the population, my demographic, the Black demographic, which the algorithm was found to be discriminatory against, well, we, in a lot of cases, don't go in as often, even though we might have the same level or same intensity of illness. We would be still less likely to go for a visit. So our spend wouldn't be counted towards this question of illness that we're trying to answer. So the biggest thing that I like to focus on is depending on what's the most important thing that you're trying to track: false negatives, false positive. But you also have to be asking the right question. That has to, and Dr. Zachary, like you had said earlier, these conversations don't surface, and populations get underserved when the right questions don't get asked.
Thanks.
Sure. We had a couple of questions come in from the audience that I really liked, because we talked about analytics, we talked about bringing visibility to the fold. But Paula Cottrell, I love this question, because okay, so we've identified these people in at-risk or adverse populations, but perhaps they don't trust institutions as much, or perhaps they're resistant to some information or communication that would be beneficial for their health. Curious, Dr. Zachary, as far as what are some of the strategies that you've seen overall work to help encourage the behavioral change needed to manage health?
Yeah, absolutely. I think most fundamentally, and maybe I'm biased because in my previous life, as I like to joke, I was an athlete. But teams. I think Paula, you called out. People think docs are magicians, and I think there's been some component where as physicians, we have thoughts. We have all the tricks in our pockets. We're going to take on the fold. We can handle it all. But in reality, again, we're quarterbacks. We need to share the ball, and we need to hand it off to the folks who really do have the tools, do have the bandwidth to be able to engage folks sustainably and in the ways that can really empower them, right? Through motivational interviewing, through cognitive and behavioral therapy, really help patients develop those tools for themselves rather than, a kind of quick 3-minute conversation where me as the physician kind of tries to tell you this is what you should be doing. Some physicians now are being trained in motivational interviewing, and there absolutely are opportunities where in 30 seconds, you can weave that meaningfully in and give somebody some parting thoughts. But when you really leverage a team-based approach, which means that you have, a community health worker, you have a behavioral health specialist, who can really invest in the engagement and the relationships. Let me just say that one more time, because again, it's humans. We're talking about humans, and relationships are often our most powerful tools. So I think really lifting up the rest of the team and not just making it a kind of a vertical structure where the doctor's on top and they kind of push out work to the rest of the folks, but really bringing everybody to what I would say is an equal standing and recognizing we're all bringing very unique capabilities and talents to the effort of taking a whole-centered approach, and really, again, lifting folks up to practice to the full capacity that they have, I think is the most effective and sustainable strategies that I've seen.
We got another really good question from the audience too. This one came from David Dalton, and it got me thinking. So the overall question: does a healthcare system have a responsibility to help build digital infrastructure for underserved groups? And the reason I like the question so much is because it kind of reminds me of the trolley problem, where if you do nothing, then one person dies. But if you do nothing, then 3 people die. But if you do something, then only 1 person dies. It's kind of a distant relationship. But the real question is, when we know that digital infrastructure, the availability of digital infrastructure improves the ability to communicate or interact or maintain relationships with these populations, does that then create a kind of a higher level obligation for a health system to then focus on how to build and replicate the digital infrastructure that they've seen working for others?
Right. 2 points, and I actually piqued another comment, and Paula, rightfully actually called out that what's interesting, as much as we know the digital care divide exists, and to differing degrees in different locales, I think at this moment we actually are often seeing that many folks do have at least some type of mobile access, but to address David's more fundamental question, I think this comes back to the recognition in my personal belief that the healthcare system doesn't now have to become everything. We when you look at kind of comparative health policy, obviously, when we look at places like the EU, there's a much more robust social safety net. In the US, the reality is that has significantly fallen on the healthcare system. That doesn't mean we need to replicate everything within the healthcare system, but what it does mean is that as a community institution, healthcare systems have a really profound political and social capital, I would say, to create coalitions, to lead coalitions, cross-sectoral efforts that involve the business community, that involve public investment to address these resources. So I would argue the healthcare system doesn't necessarily need to be the ones building this digital infrastructure. But what the healthcare system can leverage is a profound political capital, profound social capital to lean on the folks who can drive those investments, and the expertise, and the businesses, the institutions, and that can effectively create that. I think that's what the healthcare system really needs to recognize is, okay, now that I'm on the hook for these outcomes, let me leverage this profound political capital, because any locale that you go into, the city council, the mayors, even if you're talking about at the state level, healthcare institutions have a profound role in local politics. They have a profound role in local economic ecosystems as really significant employers and institutions. So leveraging that aspect to indirectly bring together those coalitions to call out these as priorities for investment. I think that's the role of the healthcare system.
That's great. That's such a great call to action. I mean, if you look at the 50s, when as fraught of issues later were discovered, but the transportation corridors that were set up, it was infrastructure. It was publicly funded infrastructure that provided the growth and the like. You kind of wonder if health systems and payers have to come together to use their political willpower to get the same type of infrastructure on access to food, to transportation, to all those things that relate to also healthcare delivery. That would be interesting.
Yeah, I think it's going to be a strategic, actually, move also from a bottom line standpoint. You could say it's incumbent now, as they become again on the hook for outcomes. Do you want to try to internalize all those resources and now have to, invest and stand up, aspects of your operations that you're not, well placed to effectively deliver? Or do you want to say, hey, I'm a really significant player in this community. Let me leverage that power, leverage that capital, political capital, to bring the people to the table who can do that, to drive the public investment that can support folks from entering into those spaces and building out that infrastructure.
Gosh, I really love that point, and I'm seeing that echoed in the comments as well. So thank you for asking the questions, folks, and thank you for carrying on that discussion. And it really gets me thinking. When you mentioned social capital, a lot of the people that we interact with on these calls, on these LinkedIn Live sessions, patient engagement, marketing, are kind of the voice of this institution that has this tremendous amount of social capital. So I'm curious, when it comes to health equity and helping to serve the underserved, what do you see as the role of the people in marketing and patient engagement in this broader picture?
It's a really great question. I think from my vantage point, what I see is really incumbent, again, particularly as we continue to move forward in this realm that's leveraging artificial intelligence to really target our messaging, to really target our engagement, is fully recognizing the data that we have, and again, leaning on that social determinants of health, leaning on those more holistic pictures to understand what is it that we actually need to be engaging patients about. What are their primary needs? And I think when we really think thoughtfully and critically about, okay, we have this picture of this patient. What do we want to optimize our engagement around? What do we want to focus on? And recognizing that these social determinants of health, these root causes of health inequity, from a patient's vantage point, are their priority. And I think if we start to reformat the communication and engagement that we lead with, that's going to go a long way towards starting to build some of that trust that you called out earlier.
Fantastic. So with time for just a couple more questions, first of all, I wanted to thank everybody, because we have gone a little bit past the hour. But there's been a good contingent of people interested in this topic. It's extremely important, and I appreciate the passion of the folks who have stuck with us on this call. One question that I think might be important, just for leaders and people who, again, heart's in the right place, but trying to make sure that the actions align. What should healthcare leaders in health systems be doing differently to, like, as we see the convergence of these new social trends, what should they be doing differently to adapt to these new scenarios and make sure that equitability and access remain a key focus in these new scenarios?
I would say investing in teams, recognizing that the best care comes from whole person approaches, and those approaches really require a multidisciplinary and even in some scenarios, multi-specialty team, particularly, for patients with increasing complexity. So really thinking about how we build the service lines that, one, bring a holistic approach and integrate, pharmacists, nurse practitioners, physicians, behavioral therapy, dietitians, community health workers. Again, really investing in those teams and creating the sustainability that allows them to work together and really come together, because that's gonna absolutely lead to transformative care. I think the second point I would say is really thinking about beyond the care continuum. We often think about care coordination from inpatient to outpatient, but let's continue to dissolve those walls and barriers and really more so just think about it, when someone's in the community, what is it that they're going to really need to be surrounded by, and what are the partnerships that we need to establish? Who are and what are those other community anchors and institutions who can start to help, one, create some of the, again, holistic data pictures that we need to really understand our patients, but also more effectively and collaboratively intervene on those needs.
And with healthcare equity, with health equity as the North Star, any final thoughts for the people on the audience? Oh,
Oh wait, was that a question
for
for me?
you.
Sorry, I didn't know if you were giving the audience a moment to ask any final questions.
Oh, no, I was asking you for your final thoughts.
Yeah, no, absolutely. I think where we stand here in this moment, where we have a profound opportunity to do right, not only because it's a moral or philosophical right, but also because it's the right business decision in the long run for your health system. So making these investments early is going to put you ahead and create what I would say competitive advantage. So I think health equity today is not just, again, a call that pulls on the heartstrings, but also is a tactical and strategic call for any health system that wants to lead as we come into this century.
And Shitalini, from you?
No, I think I love the viewpoint there from Dr. Hermes. There's a long-term approach to it. It can't just be something that's pulling at the heartstring. Like, you have to. This actually can be a competitive differentiator, especially as we move towards value-based care. So building health equity into the model allows you to be one step ahead of where the market's going. Right, healthcare at the end of the day is a business, but the marketplace is changing with value-based care. This is the secret weapon for total community health. And so we got to adapt to it, and the ones that do it early will succeed.
Well, Dr. Zachary, I just wanted to say thank you very much. I mean, I've learned a tremendous amount today. I think that we can all come from this having a more nuanced view of the distinction between health equity and healthcare equity, and even the distinction between health and healthcare, and some of the actions that have worked for breaking down these barriers. For anything else, if there's one more thing I want the audience to learn, which is a new term. It's not a brand new term, but it was new to me a couple of years ago, but it's called the McNamara Fallacy. The McNamara Fallacy is the belief, or when you're erroneously thinking that whatever data is being collected, or whatever you're seeing on spreadsheets or in reports represents the absolute truth, when there's a whole bunch of nuance, a whole bunch of different things that don't get captured on spreadsheets, that don't get captured in your giant SQL big data cloud systems and all that. So what we're going to be focusing on next week is the stuff that doesn't get captured there. It's called Patient Experience Panel 2. healthcare marketers as patients, where we're going to have people in healthcare marketing discuss their own experiences as patients, and ultimately where the health system succeeded and where there are cracks within the system. And the reason that we want to do that is just to help with a more holistic thinking around developing a patient experience, and maybe for the stuff that's not getting captured, maybe find ways to identify how to capture that. Dr. Hermes, for example, collecting information on food insecurity. There wouldn't have been any capability to take any action without collecting that information, then linking that to the problem. So it's the next week's session is designed to discuss some personal experiences around engagement with healthcare, and ultimately get some thinking spurred on how we can do to holistically approach the patient experience. But look forward to that. Again, thank you everybody who stayed princely 16 minutes past the hour. We really appreciate that. And if you want to be notified on future conversations like this, you can go to our website and sign up for the newsletter, and that way you'll be notified on a weekly basis. All right, thank you.
Thank you all. Happy Friday.
Happy Friday.
Take it easy, y'all.